This is Crystal Fend in Orlando at the American College of Cardiology meeting, where researchers reported that a device that closes off the heart's left atrial appendage can be effective as warfarin for stroke prophylaxis. Dr. David Holmes from the Mayo Clinic presented these findings at a press conference here.
We know that in the past that Coumadin has been found to be very effective in those patients. The problem with Coumadin is, and you've all talked with patients on Coumadin, you can't eat spinach, you can't eat lettuce, you can't eat all of those things because it changes your bleeding time with it and the potential for bleeding. So while Coumadin is effective, there are problems with taking Coumadin. In addition, about half of the patients that are taking Coumadin are within good control. Some of them are too thin and some of them are too thick. So while Coumadin is effective, it's oftentimes not used, or it may not be effective because it's either too high or too low. And so the device that is the focus of the Watchman trial, the Protect AF trial, says we will identify and isolate that left atrial appendage where clot comes from in patients with atrial fibrillation and study that for stroke prevention versus warfarin.
The Profess AF trial included more than 700 patients with non-valvular heart failure who were randomized to open-label treatment with either standard warfarin therapy or the Watchman atrial appendage closure device.
There's an early safety concern with the device. It's an invasive device. If you go to the catheterization laboratory, you have the potential for interventional invasive complications. Those were typically procedural related, and they were the most commonly related to the accumulation of fluid around the heart called pericardial effusion. And that was relatively frequent. In the early experience, it was about 6.5%. That has been seen with all interventional procedures, whether that be myocardial biopsy, whether that be atrial fibrillation ablation, whether it be pacemakers. There is an incidence of what's called pericardial effusion. Over the course of time, as we learn more about the procedure and as the technology improved, that decreased down to about 1%. But there was an early safety hazard, that is true. The second piece of information is that when you look at efficacy, that efficacy was dramatically better with the device and stopping the Coumadin. So the most important efficacy issue was hemorrhagic stroke. Hemorrhagic stroke, when it occurred, was almost uniformly fatal. And that was seen considerably more frequently with Coumadin. There was only a single patient in the device limb that had a hemorrhagic stroke, and that patient had that hemorrhagic stroke at day 15 after the implant when he was on Coumadin. It was double jeopardy. As you think about it then, you could summarize it and say, this device, this approach, shows superiority for prevention of hemorrhagic stroke. It shows non-inferiority for all stroke and for all mortality, cardiovascular mortality. There's a safety issue that is early on that is now better. There were increased procedural events because there were procedures. But that has been improved given that we have changed the technology and better experience. And finally, at 1 year, about 90% of the patients are off of Coumadin and never have to bother with that again. That's really the bottom line. So as we think about it, a strategy like this can be used in those patients with non-valvular atrial fibrillation to prevent stroke and get them off of Coumadin long term.
For atrial fibrillation patients, a device to close off the left atrial appendage may be at least as good as warfarin for stroke and clinical event prevention. But how to balance these benefits against the risk of complications remains to be answered. In Orlando at the American College of Cardiology meeting, this is Crystal Fend, MedPage Today.